is going to be leaving soon, this will ask you what your presenting complaint is. And you're going to be able to say, my presenting complaint is chest pain, or shortness of breath, or I have a fever. And it will say, how long have you been sick for? And you'll talk to it. And it will do natural language processing, and it will understand your language. And it doesn't matter if you come from a region where the language is different from the hospital, because it's got AI, it will recognise, and it will translate, and it will put it into the right language for the triage nurse to look at and to confirm. And so that's going to happen. And then at the minute you do that and you enter your details, and it confirms who you are, it will say you have a 95% chance of needing to be admitted to hospital. And it will tell the triage nurse and the bed coordinator for your hospital. This is just a triage. The systems are so accurate in some hospitals with the data that's available. The next thing that happens is the doctor comes along and says, what's wrong with you? And you don't have to have a pen or paper. You just have your iPhone. And you just put it on ChatGPT-4 and just record and say, please make a diagnostic note. And it orders it. Presenting complaint, history of presenting complaint, past history, medical history. The whole lot will come down, even a travel history. And if you're missing something, it will say to you, can you please ask about whether the patient has been bitten by mosquitoes? Can you please ask whether they keep budgies? Can you please ask whether they've had any other infectious diseases or anything that's relevant that's missing? And it will record all that information and put it into your clinical note, and you don't have to touch the computer except to confirm. The next thing that it can do is you can say, can you give me your smartphone or your watch? And you can put your watch on a computer like this, bang, and all your data is downloaded into the note, the clinical note. It's there. It was your heart rate, it shows if you're in atrial fibrillation, shows if your blood pressure's too high, your oxygen level's too low. It's all there, recorded for the last 30 days. The next thing, that you're going to get out your ultrasound. Some of you have been at the ultrasound course, and on the end of the ultrasound probe, it's all AI, and it says, you are looking at a wall motion abnormality in the heart, or there is fluid around the liver. And again, automatically by Bluetooth into the clinical note. It records it, and it puts the picture in, and the picture gets sent to a radiologist to confirm. Not only that, all the laboratory and radiology that you order, not just the report, but the pictures as well. And the AI system will take that report and look at previous CT scans and previous ultrasounds and say, hang on, there's a little lesion that's getting slightly bigger, but that the radiologist may not have reported on, but it can see it happening over many times. And the AI system will pick it up and say, looks like it could be cancer. So that's happening now. And then, of course, you get your chatbot out because you're a little bit confused, and you ask your chatbot, what's going on with my patient? And the chatbot has a differential diagnosis, says this is the most likely one. And you go, oh, okay, I will look at that and maybe go and ask a few more questions to confirm. And that will have a full differential and the percentage likelihood for your patient. And then decision support, you heard about it from Dr. Cameron early on. That decision support will help guide you to the next things that you need to do. It might be a further test, it might be admission to hospital, and then following that, if the patient's allowed to go home, it will print off the discharge summary in the patient's own language, and you can hand it to them. And that's what's going to be happening, and is happening now. All these things are real. I'm not telling you any lies. This is not the future, it is now. It is happening now in hospitals. The trouble is, it's happening in different hospitals around the world, not just happening in one hospital. So, but this is the future. This is what is going to happen, and with AI. And so we've got a very exciting future to look forward to. But before we get there, we need to do some things. So next slide, please. A little bit about AI. It's been around for a long time. And we go back to the 1950s, and that's when it actually started. So what is AI? Well, it's technology that tries to emulate the human brain, how we think. So that's been going on for a long time. And there are challenges out there to try and get people to be fooled by AI. Is it a human? Is it a machine? And those tests that were set up in the 1950s have just been passed in the last 2 or 3 years. And so now it's getting harder and harder to work out whether the person at the end of the electronic message or even phone call is actually a robot or is a person. And so now we are really fooling people. So, but that's been around for a long time. And then in the 1970s, machine learning came around. Machine learning works off databases, big databases, and it works out patterns in the database. So it might be able to see a pattern here and say, well, we recognise this pattern from our database. This is pulmonary edema, or this is cancer, or on mammograms, breast cancer, or something else like that in the medical field, but it recognises patterns. And then, just recently, deep learning. Deep learning is when the computer system says, oh, I know how to recognise patterns, but now I can see another pattern for me, and I'm going to link those patterns. And so it's able to work between different patterns and make suggestions. This might be something different. It could be that there is a lesion on the mammogram, but a chest x-ray shows a lesion in a bone. And it puts out, oh, hang on, this is breast cancer, metastasized to the ribs. And it links the two different pattern recognition. And then very recently, 2020 is only a few years, and now you can do what's called generative AI. Now, look, you might know generative AI, you can download it on your phone. I was playing around with it this morning, and that's the sort of thing where you can say, please draw a picture of a cat riding a surfboard on the moon, and it will do it. And it will do it different ways, and you can add it to do different things. And so generative AI is very interesting, but in health, what that means is if you have a multi-resistant drug problem with, say, TB, you can ask the system to develop a one for this particular patient with these biomarkers. What is the best drug? And generative AI will work out a drug that you can then go and synthesize in the laboratory. That's going to be perfect for that. So that is going to be the future. It's not quite here yet, but that is truly the future. But it is happening, and it's happening in health. Next slide, please. So where does all this data come from? You heard Dr. Cameron say data is what we need. Well, it's everywhere. We've got machines, what's called scraping machines that scrape the internet, but we've got some big online repositories, databases, and they hold data and images so that you can compare. And then we've got private data sets that are out there, and these private data sets, they buy data and they sell data, and they make a lot of money out of doing that. And then you've got social media. Every time you get on Facebook or Instagram or any of those things, you are the product. You are giving data to these companies that they are then selling to companies so that they can sell you things. And so there's massive amounts of data. And then, of course, there's user-contributed data. For example, my son wants to go into space, and there are data out there where you can look at a small part of the world, night sky, and you can find new things, and you submit it to a database, and across the whole world, everybody, little people just doing things on their computers, suddenly you're able to make new discoveries. And so that's happening. But in health, and this is the key, the electronic health record is where that data comes from. And the electronic health record has demographics, that's who you are, what your name is, what your date of birth is, and timestamps. When you went to the hospital, what day, what date, and how many times, and then the lab and radiology results and the images, as well as special investigations like an echocardiogram or an endoscope, and then the medical records themselves, people typing into the medical records to say this was the diagnosis, and in my area, ED information systems using the data sets that I put in that you can pick and choose your presenting complaint and your diagnoses from. That all goes into these systems and it's coded. And I told you before I use the SNOMED coding system that's quite new. Next slide, please. With any system that we're going to use, you've got to make sure that the data that goes in is good data, because if you put garbage in, it doesn't matter how good your AI system is, garbage will come out and you can't use it. So garbage in, garbage out. You've heard it before, I'm sure. The other thing is that if you have the best AI system in the whole world, but you're putting garbage into it, it's still going to put garbage out, even with the best AI system. So you've got to make sure that the data is the thing that is the most important, because this could be an okay system, but if it's very good data, it will be a very good product coming out. Next slide. And this is the difference between many parts of the world and where I come from, where I've got very good access to data because we have lots of computers and databases that we can access. And this is a problem, and it's a problem that's starting to be solved in Nepal, and There is massive changes happening, and as you heard, Nepal is in a great position to be able to leapfrog and to get some of these very good systems in place if we think about it now. So countries with an electronic health record, the patient record is held within the hospital, it's in the system. The patient doesn't carry a notebook, they don't have any paper, they just go home. They go to the emergency department and they have nothing, they do not have anything, details, and the system will find who they are and their record is all held in the hospital. And then we add to that in every different department, outpatients departments and radiology and the operating theatre and the emergency department, and makes it very easy when those patients have a single unique identifier. One number, and so my number, I know what it is, and I can go up and I can say my number and they know straight away whether I have any allergies, any alerts, who I am, where I'm from, where I live. It's all connected. And so once you've got an electronic health record, you can start sharing data and you can start coalescing data and putting it into the same system. And from that data, that's where the AI stuff gets really good, because it's local data and national data, it's our data, and it works for us. But without an electronic health record, getting that data is very, very difficult. Next slide, please. Okay, this is Nepal. This is from the Cheers Hospital in Bhaktapur. So this is an AI specialist or an engineer. These AI models lack the ability to contextualize like humans, and so when they are deployed in areas where medical records are sparse and data sets are biased, a biased data set is a data set that does not apply to the population, it affects the precision and dependability of the AI forecasts. And so from that, this is only a few years ago, the Digital Nepal Framework has provisions for a national digital health mobile application, more importantly, a comprehensive EHR. And I think that's something, Ramesh, that you are going to be very interested in the next few years. And so many AI projects can still work, but they're isolated. So you can detect cervical cancer using special cameras. You can do retinal imaging with your iPhone, but unless it's connected to the bigger system, it's going to be just a very small AI and maybe not have a big impact across everyone. Next slide, please. Okay, so this is Dharan, 2014. I took this picture, and Dharan has a computer system, a beautiful computer system. It worked very well. I used this computer system to think what I could make my computer system. So Nepal has the technology, it is there, but it's not being used in every hospital. Next slide, please. That's my computer system. It looks a lot like the one in Dharan. So I was very lucky to go and visit Dharan. But you can see here, red, that's the presenting complaint, blue, diagnosis. Next slide, please. And so on my system, the doctors put the diagnosis in because we don't trust other people. Why shouldn't we not put the diagnosis in? At the moment, you write it in the patient's notes, yes? But in us, we type it into the electronic system and we can change it and we can add to it. So you can have one presenting complaint, multiple different diagnoses. If you're involved in a car crash, it's major trauma. But you might have a pneumothorax, ruptured liver, fractured femur, and so you have multiple. Next slide, please. But this is how you make it very easy, and Ramesh, this is something you might be very interested in. So it's all good and well having a big database with lots of different presenting complaints. We only have 150. There they are, only 150. And I put this on laminated at triage, if a triage is done. And if you want to type in AFib, in the old days you typed in AFib or atrial fibrillation or afibrillation or fib flutter, something like that, and it was a mess. You couldn't get any good information from it. In my system, you type in any of those, the only thing that comes out is atrial fibrillation, and it gets coded as atrial fibrillation. And then we know how many people have atrial fibrillation. Simple. Next slide, please. So the whole idea of doing that, and what we've done in New Zealand, is that I've been on a committee that has put that laminated spreadsheet into every emergency department, and now you're not allowed to choose a code that is not on that spreadsheet. And so it's gone around the whole of New Zealand, as well as the diagnosis, which is 1,500, and everybody in New Zealand, you can't pick a code that's not on the list. So there is one source of country, and many of the small hospitals are using it more and more and more, and we're now to 100% usage across the country. The idea is you have a conductor, that's the Minister of Health, and that's all the different emergency departments, and they're all singing the same song. And when everybody is singing the same song, the result is that you get really good data, and as a result, really good information. You've got to do this. Next slide, please. There's lots of barriers, lots and lots. You can read all those. The biggest one is not getting involved. Remember, I'm not a computer person. I've no training. I'm a doctor. I'm like you guys. I am no different. But they asked me to do it, and I thought this was a good thing to do. And so I decided to sit down and learn. And I learned it. And I learned it while I was doing my job and still doing my clinical practice. And I've learned a lot, and it was really quite interesting. And as a result, we now have probably one of the best systems in New Zealand, and it's now going to every hospital in New Zealand. So from small things, big things grow. That should appeal to my Australian colleagues. You know why. So that's the biggest mistake. So if somebody in your emergency department has an interest, for all those people in senior positions, please allow that doctor to grow that interest, because this is how you develop really good systems. Next slide, please. And so what I'm going to encourage you to do is exactly as Dr. Cameron and Professor Henry have both said, is that you want to start with the end in mind. You want to work out what it is that you want. And that's what I did with the data sets, the SNOMED codes that we have in our hospital. I thought, what information do we need? And then from the information, you then step back and say, what data do we need to collect to get the good information? And that's what I've done. It's very simple. It's not complicated. It just takes time. And so I worked out what we needed to do, and I worked out what the building blocks were, where it was going to come from, and very importantly, who's going to do it. And I decided the best person to do it is the doctor. And that's why I've made it very easy for the doctors and the nurses in my emergency department to do the codes. It takes 2 seconds to do a code. Just quick type, it's in. And so it's very accurate, point of care, and very trustworthy. And so we are coding right at the front of the hospital when the patient's right in front of us, we're doing the codes. And usually that's not the case. Usually it's done many days after the patient from the old handwritten record, but we got rid of the old handwritten record. It's all electronic in my hospital. So again, the best solutions for ED are those ones designed by ED clinicians. Now, I've told you so I want you to be optimistic, but I want you to also be a little bit cautious. Don't go accepting products that come from elsewhere promising they're going to save the world, because they're not. You're going to save the world. You already are saving the world, but it needs to be stuff that you guys have designed. Don't rely on people from the outside to deliver all your solutions. It has to come from within, because you know what you need for information and data, and so it has to come from you in the room here. Don't let other people tell you what you need. You should decide that. Next slide, please. Okay, another local hospital. Who here has been to Iopata Hospital? Anybody? Yeah, somebody at the back over there. Yeah? Okay, these guys are leaders. They have got an electronic health record in their hospital. They triage. You come to a triage station. You are automatically logged in. You then get sent to the emergency department, or you get sent to outpatients. And it's all electronic. And they get a single unique identifier for their patients. It's happening. It's happening right now. This has been up and running for 2 years. Very impressive. Go onto YouTube, type it in, have a look. You'll see some very excellent doctors who are working the system. It is happening, and they are putting AI into the system. Nepal, EHR. So very, very impressive. So it's happening out in the provinces, and that's often the way it happens. I'm from the province. I'm from a tiny place called Nelson, very small. Auckland, we know all the answers, but no, sometimes the provinces is where the good one. I think that might be my last slide.